everyone. Thank you for coming out on this snowy Thursday night to join us. My name is Kristen Van Dyke, and I have the privilege of being the Executive Director for the Foundation for Hearing and Speech, and also the mom to my son Max, who was born profoundly deaf and was implanted as a baby by Dr. Young. Thank you very much for giving my child the gift of hearing and the ability to speak. He's 13 now, so that's fun. Yeah, it's really good. So for those of you who are unfamiliar with the foundation, we've been around for about 60 years, and we focus on funding programs that allow children and young adults to fully live out their lives. Kids in Illinois who have hearing loss, we like to provide programming that helps with their education, equipment support, social interactions, because our goal is for them to be on par with all of their hearing peers to the best of their ability. How do we do this? We have 3 areas of focus. We focus on clinical services, education programming, and music programming. Our clinical services, we are honored to support programming over at the Ann and Robert H. Lurie Children's Hospital of Chicago with the Heart Family Cochlear Implant Education Coordinator, Jen Haney. I think you're here, maybe Jen's not here. With Jen Haney, it's an amazing position where she goes out and she directly supports all of the families of children who have cochlear implants in their process of going to school and how best to support those families and those children. We also help fund the social workers over there. We feel social workers are key to getting families on the path to success, and helping them coordinate their services, and the loaner hearing aid program, something that I'm sure those of you who are in the hearing loss world understand. Little kids with hearing aids is always a problem because they're always being lost, dropped, broken, eaten, something. So we like to make sure those kiddos have some hearing aids to get back on so they can get back to school and get back to life. In addition, for education programming, we work with Chicago Hearing Society to expand their Read Day and their Dear Day, their literacy programs, down to central and southern Illinois. We are honored to be a part of that, and we hope to expand our education component in the coming year. So be on the lookout for some new and exciting things that the foundation is going to do programming-wise in the education world. And about 2 years ago now, we celebrated our 60th anniversary and began a lovely program called the Music to My Ears Scholarship Fund. This program provides tuition-free music classes for children up to 4 years of age with our key partners, Old Town School of Folk Music and the Merritt School of Music. We firmly believe in giving the gift of music to children with hearing loss. They should absolutely have it in their lives. We love the fact that we see them being engaged. We're so committed to this program, in fact, that our directors have expanded the program. So now we're offering children instrument lessons and vocal lessons. And we have recently started music class programming at Child's Voice, and also we're starting after-school programming at the Trinity School for the Deaf. These are classes that are changing these little kids' lives and seeing them. Sally Blandon is here. She is our instructor and in charge of our classwork and our after-school programming. It is an amazing thing to see when you get these kids all in a group and they start rocking out and enjoying music. So it's lovely and something we do hope to continue to expand. We really do strive to do everything we can to make sure that children in Illinois who are living with hearing loss have access to everything they want to be successful. And we are happy to build that community with you and with the families and really show that there's lots of support out there for the families and lots of support out there for the service providers and the educators and everyone who's working so hard to help get these kids on a path to be as successful as they can be. So thank you for being here. We are so appreciative of all of you being here. I will stop talking and turn this lovely evening over to our esteemed panel and to Heather Bennett, who is one of our board of directors. She has really spearheaded and coordinated this event and done an amazing job. Dan Lockwood, who is sitting quietly in the back, has also helped greatly to put this all together, and we so appreciate their work. Heather, in addition to being on our board, is in social media and marketing. She's a force to be reckoned with, and she also has a daughter, Raquel. She's the mom of 4, but Raquel, her youngest, is 8 years old, who's adorable, and she was born with hearing loss, and that brought Heather to us. So we are so grateful to have her here. Without further ado, Heather Bennett.
Thank you, Kristen. That was really sweet. So welcome, everyone. We're so very happy that you are here. In the audience and on our panel, we have a very broad cross-section of professionals and individuals who work with children across all aspects of their lives with hearing loss. So we're grateful that you're here. And the main purpose of tonight's event is so that you can all understand where you fit in the lives of these children. I always talk about Team Raquel being, my daughter being here, and then she has all these people helping her do what she needs to do, and how important it is that they can all communicate together and work towards making her life work well. So thank you so much for coming. I'd like to introduce you to the panelists. So we have Dr. Nancy Young, who's a leading researcher, surgeon, professor of pediatric otolaryngology at Northwestern University Feinberg School of Medicine. She's currently practicing at Lurie Children's Hospital and has performed over 2,000 cochlear implant surgeries. Dr. Young is dedicated to understanding the impact cochlear implants have on language for deaf children. Megan Roberts sadly came down with a bug and is not here today, but we'll be looking forward to talking to her in the future. Brandy Sider is a speech-language pathologist, certified listening and spoken language specialist, and auditory verbal educator, and is part of the Lurie cochlear implant team as well. With over 12 years of experience in speech pathology and oral habilitation, Her work focuses on both speech language and oral rehabilitation therapy with children, and we'll hear more about that a little later. Diane Salk is a DHH certified teacher in the Chicago public school system. She's currently teaching at Bell Elementary School in their pre-K classes. Her extensive experience with deaf, hard, and of hearing children allows her to have a unique perspective on early intervention and supporting teachers of the deaf. Dr. Michelle Gozdecki is a pediatric audiologist working at Comer's Children's Hospital at the University of Chicago. Her work focuses on helping her patients find the best treatment possible when considering the entire medical history of the child. And she was a featured speaker at the American Academy of Audiology 2019 National Conference. Thank you for being here. So let's get started. So during this discussion, we're going to start from identification, which is when a child is identified as being deaf, through possible treatments and therapies, and then on to how they enter the education system. So we'll start with identification. Dr. Michelle, what should families expect at an initial evaluation?
So at an initial evaluation, really the first thing to expect is that your audiologist will ask you a thorough case history about your child. So some of those questions could be pregnancy and birth history, if your child passed the newborn hearing screen, if your child was ever admitted into the NICU, if they have any other diagnosis, how their general health is. The audiologist then may move on to if you as a parent are concerned for their hearing or their speech and language development. They also may ask if your child's had any ear infections, if there's a family history of childhood hearing loss, and then sort of if your child's in any therapy or what type of school your child goes to. So those are just some questions that might be included in the case history. After that, they move on to taking all that knowledge together and then deciding what is the appropriate test to complete.
Okay. And then you talk about testing. So what can parents do to help their child get the best test possible? Or like a few quick things that parents should keep in mind.
So if you're bringing in a baby, we as audiologists would prefer if your child was asleep. So especially if they're under the age of 5 months, it makes our job a lot easier. So that is bringing them tired and hungry is always the best bet. And then for our older kiddos, really just talking to them, like, we're going to do a hearing test. It's going to be fun. We're going to play games. For one of the testing that we do, it's called visual reinforcement audiometry, and it's where the child will actually sit on your lap. So they feel comfortable. They're with their parent, put some headphones on, and they look for different sounds, different light-up toys. For our older kiddos, we actually play a game. So we try to make it really fun. So it's nice when parents kind of talk it up, like, okay, we're going to go do a hearing test. It's going to be lots of fun, no ouchies. Kind of talking them through the process so they know what to expect is always really helpful.
Okay. And then since you work in an audiology clinic, what are some unexpected ways that our audience may not know that audiology clinics can help their patients?
So I think one of the main things is that audiologists are happy to work with other providers, kind of like we all are getting together tonight. So if your child does go to therapy, whether that's through early intervention or a private therapist or maybe even through school, it's nice for the audiologist to be able to connect with the therapist so everyone's on the same page. And then relating to school, audiologists can help with IEP plans or 504s, just making sure that your child's receiving the services that they need in the classroom. So we're happy to help with that. Other things that I think we don't think as often about is just that we can connect parents and families to other families that have children that are going through the same thing, even if the parents want to talk or meet up and the kids can meet too. That's always really nice. And then as we think about summer coming up, there's lots of camps too that audiologists often find out about that are specifically for children with hearing loss. That's always nice for the kids to go and meet other kids just like them and kind of talk to them about their experience too.
So you talked about early intervention. Dr. Young, could you tell us a little bit about why early intervention is so important?
Well, early intervention is, I mean, it exists for a reason, so what you want to do is address a problem. Oh, is it not on?
We want to hear your voice. Maybe you'll have to share with Michelle.
Okay.
Thank you.
All right, I'm happy to share. So, early intervention, there's a lot of research that by intervening early, potential delays and gaps in development can be addressed and potentially eliminated. And in our world, the hearing world, what's very important, well, number one, what's important is to find out the parent's goals. And that's something I always ask my families. And if that parent's goals includes they want their child to develop speech and language, a very important component of the therapy, because there can be many different therapies kids need. But if the goal is listening and spoken language, then hearing therapy. So someone who can help a child develop age-appropriate listening skills is critical, because listening comes before speaking, right? Our kids, when they're babies, they're listening before they're speaking. Well, when we give children hearing aids or implants, that process has to happen, and hopefully a bit sped up, so they make up for the gap, for their deprivation.
And you had talked about cochlear implants and other technologies. Dr. Young was the first surgeon in Chicago to perform a pediatric cochlear implant, and that was in 1991. How has the technology for cochlear implants changed since then?
Well, since then, there have been many, many changes. I mean, everything is much smaller. When I started, there's externally worn hardware, and there used to be a big box you'd have to wear. So I think I'm going to focus on maybe some of the more recent changes. And I'm going to give my perspective, which is obviously a medical perspective. So one of the recent changes has been in the technology, the magnet technology that goes into implants. And you're thinking, well, what's with the magnet? It has nothing to do with hearing per se. It doesn't help the child hear. But there's a magnet inside the implant, and then there's a magnet in the externally worn coil that keeps the internal and external components in alignment so that the sound can be transmitted into the device, okay? And originally, these magnets prevented children and adults from getting MRIs. But when implants were new, MRIs were new too, and they weren't done for many reasons. And there weren't very many MRI machines either. Now MRIs are everywhere, and they're done for just about everything. And so it's very important that our patients have access to this important medical technology. So the original devices, it was not advised, and the companies have come up with different strategies over the years to address this issue. And in 2015, I think a real breakthrough happened where one of the manufacturers came up with a diametric magnet. So it's and the FDA gave permission for MRIs without removing the magnet surgically, which was another strategy. And that's been great. And what happens in the implant world is when there's a successful development, then competition goes wild, and the other manufacturers figure out some way to offer the same type of feature without breaking any, copyright or whatever you call it, without any patent infringement. So, and that is really, with magnets, has happened. So now all the companies are offering a version of this. So I think that's fantastic for our patients. The other areas, which I think there's a lot of new fun things relating to the external processor. For a number of years, what's been very popular are these button processors where nothing's actually hanging on the ear. It's magically sits on the side of the child or adult's head. They were very, very popular. But the batteries were not rechargeable, so we had a breakthrough recently. Now, one of the manufacturers has developed a rechargeable battery, which is super helpful, so I'm sure the other companies will work on that as well. And streaming. Bluetooth is huge now in all of these devices. But what I thought was really interesting is now several of the manufacturers offer sort of a Find My Phone aspect, so you can find your child's processor by using an app. So I think that's fabulous.
Okay, that is really huge. I could talk more about that, having lost them on occasion. We'll go, so in terms of parents or candidates for cochlear implants, what do they need to know? What would you like to tell them that they should know before they consider an implant?
Well, there's so many things we could talk about, but probably in terms of if your goal is age-appropriate spoken language, and we're talking about a baby that was born or developed hearing loss early in life, it's minimizing the period of time the brain is deprived of useful auditory input. I mean, access to all the sounds that are contained in speech. So I think that's really, really critical, and there's just an overwhelming and growing amount of research that access to sound early results in more rapid progress and more likely to have a better outcome. I mean, there's tremendous individual variation because this is really about the brain, what happens. I've had patients that just have completely amazed me, have done things that I didn't think were possible. And on the other hand, we've had patients that, don't make as rapid a progress as we would like. But the way to maximize the outcome is definitely younger age if a child was born with a significant hearing loss.
Okay. And I know Dr. Young has done a lot of research in this area, so if we have time, I'm going to come back to you and ask you more about that. You had talked about the importance of speech therapy. So Brandy, if you could tell us a little bit about what's the difference. You talked about listening and speech therapy. So what's the difference between speech therapy and oral rehabilitation?
So oral rehabilitation is that listening side of therapy. So when we think about hearing, a lot of times we think that hearing is at the level of our ears, but really, as Dr. Young said, we hear with our brain. And regardless of when you get implanted, it always takes time for brains to make use of complex sounds. So if you think about complex sounds as being both environmental and speech. So oral rehabilitation is exactly what helps children learn how to make sense of that. And I mean, it also works for adults too, but for the purposes of this, we're, dealing with our kids. And oral rehabilitation really focuses on parent involvement and family coaching, because we also know that the hour of therapy a week is not going to make any sort of difference. So we have to really partner with our families and meet them where they're at and ensure that they're understanding, generalizing, and carrying over our strategies that we're using within therapy. Also, kind of to piggyback off Dr. Young, with our kids getting implanted younger, the goal of oral rehabilitation is for them to stay as developmentally on track as they can, because we know that our kids can catch up.
Okay. Yeah. You've kind of discussed a little bit, so kids need both the speech and the oral hab.
Yeah.
Could you talk a little bit about how both of that gets accomplished?
Yeah. I kind of skimmed over the speech therapy side of things. So speech therapy is a broad term, just to kind of define it. It's any sort of difficulty with communication. So that can include receptive expressive language, vocabulary, articulation, voice, fluency. It's a pretty broad term. And really, most speech pathologists don't have the knowledge and the understanding of listening. So that's kind of my caveat going into this kind of discussion. But kids with hearing loss do benefit from both. I'll also say there's no one-size-fits-all for therapy. So I can't say that they both need this dosage because it's very individualized. But I would say the AR portion is really important so that we know that they're listening and hearing what they need to be hearing, because if it's not going in clearly, it's not going to come out clearly. But with the hearing loss, we also know that there's residual, deficits with articulation and vocabulary and specific grammar needs, that speech therapy can come and kind of clean up in a more structured, one-on-one kind of remedial way.
That makes sense. And then to talk specifically about before and after a cochlear implant surgery. I know Dr. Young had mentioned that the therapy is important around that event. How does that look? What
Yes.
does that look like?
So pre-CI, before the implant, a lot of what we do is parent education. So we work on full-time hearing aid use a lot, as most professionals out there know. That's a hard thing and a big hurdle to jump over. We work on assessing what they're getting from their hearing aids. So we also need to prove from a clinical side that they need a cochlear implant. So what can they hear? What can't they hear? How are parents understanding that information? Lastly, we really work on strategies with the parents that they can use both before implantation, but they're also going to use after. So that families really want something tangible to work on before their implant. So this is a big area of what we do so that they feel confident after their implant. So that's before. Then we get the surgery, activation, and then we get to put all of that work that we did beforehand into, kind of put it into action. So after the implant, we help children really make meaning of what they're hearing. We want them to detect what they're hearing, know that it's meaningful, identify it, and then ultimately comprehend what they're hearing. Again, through all of that, we are working with the families on different approaches so that they can be successful.
Do you want to? Yeah. Go ahead.
Yeah, I'd like to, that was a lovely encapsulated summary. I'd like to make a comment on it, like what I've learned from parents. And I sort of see my role in some ways as trying to explain to parents the importance of everyone else who the child will be seeing. Because sometimes, when the parent's nervous about surgery, it's like, ooh, it's all about the surgeon, it's all about the surgeon. But the outcome in the long run, the surgery is just the beginning. The outcome really has to do with the programming that the audiologist does, the quality of that, and we really believe that it needs to be customized to the child's individual needs. The therapy and the support they get at school, and the parent themselves, because this is something, it's not like a hip implant. Without the parent's cooperation, the child won't be wearing it, okay? So the parent has a huge role in this. And the EI provider, and this gets into Megan Roberts, who's not here, who is amazing. I'm her biggest fan. But, you can have, I think what makes a really talented therapist is not just their knowledge and their ability to work with the child, but their ability to educate the parent and to work with different types of parents and teach them how to work with their child. And no one has ever studied that sort of special sauce, like what is the magic ingredient that makes that, what are the ingredients that makes that happen and makes that work well? And that's something she's doing in a very scientific, quantitative manner, which is not easy to do when you're dealing with little people. So I think that there's going to be a lot that we're going to learn from that to eventually improve the quality of early intervention.
That was great, Dr. Young. That was exactly what I was going to ask you to explain, so thank you. So talking about, I know we had mentioned activation. Dr. Michelle, could you explain what activation is for maybe someone in the audience who doesn't know what that is?
So activation is the most fun day
It is.
because it's like the hearing birthday. So it's after surgery. It's when you actually turn on the implant. So it's a really fun day. Normally we have lots of family members come and we work with the child to put the processor on, make sure it fits okay, make sure the magnet strength is okay, and then we actually go through different steps to turn on the internal device using the processor and find a level where the child's hearing for the very first time through their implant. So it's really exciting to always watch the response of the child. Sometimes we have a laugh, sometimes we have tears. It just kind of depends on the individual child, but it's always a really exciting day where the first time they're actually hearing through that implant.
Yeah, let's go ahead.
So I wanted to comment on a couple of things that both of you have said, and kind of giving my perspective from talking to parents. So, you know, Brandy referred to the hearing aid trial, and I think Michelle would probably agree with me, but often we know that some of our patients are candidates before the hearing aid trial. We know that from, there are tests that we can do, behavioral tests as well as tests with the baby asleep, where we can measure electrophysiologic responses. We often know, and one of the things that I think is very hard for parents is like, okay, you know, you told me my child is deaf, like, why are we doing this with the hearing aid? And I think that's, and why are we doing therapy with the hearing aid? I think it's very confusing. On different, and parents are all different, what they bring to this. So I tell parents, I don't know if you know this, but what I tell parents, it's sort of like, you know, putting oil in a motor. Okay, so you know you're working with a child, and even if they have the littlest bit of detection in their learning presence or absence, then when they can hear through the implant, it's like, aha, that's what this person has been asking me to do all of this time. So it really, really speeds the process, and it makes it easier for also the audiologist to program the child. So, you know, I sort of feel myself as sort of the coach that's kind of explaining like why these things, you know, are important. And then the other issue is there are many parents that simply do not believe the results of any of these tests. So you know, and I know, that the child is a candidate for an implant, but the parent, it's invisible. Why should they believe any of us? And so the therapy is often the thing that you are often the person that convinces them that the child really isn't hearing, that it's not just that they're having a bad day when they see Michelle. So, yeah, always. So the therapists are really, really critical. I mean, surgeons tend to think that it's the way they put the device in, but I think it has a lot more to do with what Brandy and Michelle do.
Okay, so now we've identified that the child is deaf. We've given them some treatment options and a lot of therapy, having gone through this, a lot of therapy. And all of a sudden, we have to send them to school. So Diane, what are some of the best practices for teachers to support deaf students in the classroom?
So you don't have to send them, you get to send them to school. It's very fun. It's a fun place to be. So we hope that teachers, when they get a child in their classroom who may have hearing loss, will do things like pre-teach vocabulary, because that can be very helpful for kids who may not know the vocabulary going into something, whereas we may assume the rest of the class knows it, but it's nice to pre-teach vocabulary. We can fill in some gaps if we know that there may be something that they don't have prior knowledge of. It's nice to be able to give them that information before something else is taught. Make sure the teacher's monitoring progress. You make sure the teacher is familiar with their hearing device, any devices that they're using. Make sure teachers, make sure that the kid is wearing them. Make sure that they're working. So teachers can also help children do repair communication. If they don't understand a child, if the child isn't understanding the teacher, there's some repair skills that can be taught, and the rest of the kids in the class should also know how to do that. So, and we teachers can help kids become advocates for themselves, and parents can really help us with that too. If the child is signing, it's nice for teachers to learn some basic sign. If the teachers can use a lot of visuals are helpful for students. And if you do, as a teacher, present some visuals for the kid, please allow time for the child to actually look at the visuals before you go on. And this is not just helpful for the kid with the hearing loss, by the way. A lot of other kids in the class could use this as well. And if the child is using a sign language interpreter, please, as teachers, understand what the role of the interpreter is and how to most effectively use the interpreter.
And then to build off of that, what are your top tips for educators and administrators to make the classroom setting more friendly for deaf, hard of hearing children?
Sure. So, one thing is seating. I mean, often these are things that are in the IEP. They're part of the accommodations and modifications that children should have preferential seating. But teachers can also, let the child know that if there's ever a time where you need to get up and move, that's okay. If it would make it easier for you to have access to the information, and even though I just got through saying that presenting things visually is a good idea, it's also not a good idea to have visual clutter, which often happens in a classroom. There's too much on the walls. So, teachers can be very aware of what's visually around the room. Paying attention to noise levels, and not just voices, but chairs scraping. I've seen tennis balls at the bottom of chairs, which can be very helpful. But just paying attention to fans and air conditioners and where the child sits in relation to that noise is helpful. So, yeah.
And then you had mentioned IEPs. Could you explain what an individualized education plan is?
Yeah, so you notice we keep saying that. All of us keep saying it's all individualized. And I mean, at every step of the way, there's not one way for every kid, right? So an individualized education plan is a legal document that is specific to that child, that includes general information, linguistic and cultural needs, goals that are worked on as a team to close the gap, and accommodations and modifications, transitions if the child is transitioning to high school or from pre-K to elementary school, and then the start date, and again, all of these being very specific to that child.
Okay. And then just a few things. How can families best advocate for their child's education? Just a few tips.
Yeah, so, one thing is just when you come to the IEP meeting, parents, the biggest thing I think is just to be aware that you are such an important part of that team. Your input, your suggestions, your comments, your questions are all very valuable, and you have to just go in knowing that you are a part of that team. And sometimes I know going into those IEP meetings can be very intimidating, and everybody's got their laptops open, and you're sitting around a table of professionals, but you are every bit a part of that team, and every bit as important, if not more important, because you know your child better than anybody else on that team. So that's a big helpful way to advocate for your child and know your rights as parents.
Okay, so I think we've had a pretty good journey here going from identification to education. I think the next question is what's next? So Dr. Young, what's next for your research or for the community?
Okay.
We're just chatting. It's okay.
Yeah, okay. Well, I'd like to highlight, there's two areas of research we're working on that I think have to do with the future. One is, I think, in the near future, and that is our implant program at Lurie is leading a FDA clinical trial sponsored by one of the major manufacturers, and the goal of this clinical trial is to get FDA approval for the cochlear implant in infancy. For many years, probably at least 20 years, the FDA guideline is 12 months, but in practice, infants are being implanted. It's just an off-label use. I mean, most of you, when you take an antibiotic, the FDA approval for that antibiotic was probably not for the use you're taking it for. So we can use things off-label, but unfortunately, when you do, insurance companies can use that as a reason not to approve it. So it can be a real fight for children who are candidates, who are for parents that want to be proactive to get the kids implanted at a young age. So one of the main goals of this clinical trial is to get FDA approval for under 7 months, and I'm very optimistic that we will, because there have been a number of large studies, including our own recently published one we did before this clinical trial, which is a clinical trial is a prospective study as opposed to looking back at your experience. So when we've looked back and other people have looked back, we found that infant surgery we can do safely with modern anesthesia and modern techniques, as we can do for kids older. But with this clinical trial, where we think that we'll get infant implantation FDA approved, and that will benefit all children in the U.S. So we're very excited about that, and there are 6 centers involved across the United States. So that's a great thing. The other study we've been working on for a really long time, and we recently got NIH funding for it, and it's going to be a good bit of time before this comes to fruition. But one of the things I alluded to earlier is we can't always predict how kids are going to do, and therapy is important, but some kids need less than others, and other kids need a lot more, and we don't always know who that is in advance. And it would be nice if we could predict. So we've been trying to figure out how to predict outcome. And, I've said multiple times, and other people up here have said, age is important, younger age. But even with younger age, that we can't necessarily predict who's going to struggle and who's not afterwards, okay? So what if we could? Because age alone is not a guarantee. So we're looking at taking information about the brain from imaging studies and using that to predict outcome for the purpose of then developing custom therapy, both in terms of type and dose, to improve the outcome. And we recently had a publication that showed that this was a proof of concept that we could actually do this, and it uses machine learning, which is a form of artificial intelligence, so we build models and teach these models based on past patients' experience, what type of brain is going to have what type of outcome. And so this is something that is going to take a lot of work, a lot of work from other centers to collaborate with us, but we really hope that someday this is going to make a difference and will make life easier for people like Brandy, and hopefully even be cost effective, because we're not going to have to throw the kitchen sink at everyone.
Which is good. I think there's 2 points that you brought up that are very important, that have been brought up a few times. The fact that treatment and therapy and education, this is all very much an individualized thing per child. And then the second thing is the collaboration. Is the only way we're going to be able to move forward is to have collaboration across multiple centers, multiple schools, multiple areas of the country and the world. So I think there's huge opportunity there. There's one other area I wanted to touch on for what's next. Dr. Michelle, I'm going to ask you this. Can you talk a little bit about some of the cool technology that's coming out?
Sure. So Dr. Young referenced this earlier with the kind of find my iPhone, find my processor, find my hearing aids. That is newer and has been hugely beneficial for numerous families and probably recipients themselves, adults too. One of the other things that is newer is the direct compatibility for hearing aids and cochlear implants to tablets to computers via Bluetooth. So this has been really helpful for our kiddos in the school, because schools are doing so much more on tablets. So they can often pair their device directly to the tablet and stream. So it takes out the middleman of the Roger or the mini microphone, that accessory, where you don't have to worry about that anymore. Instead, we can use Bluetooth. So those are a couple of the newer exciting ones. Another thing that's coming out more for hearing aids is that they're finally developing rechargeable batteries, which is huge. Still working on how to incorporate the FM system with the rechargeable batteries, but that I think will be so helpful too. Those are some main ones.
Yeah, that would be one of the things I think will be most interesting, is to see the power component. As Dr. Young stated, at the beginning it was a large pack that the kids were wearing, on their backs, and everything's moved smaller. But I don't think we're quite there yet with the rechargeables.
Yeah.
Especially with there's a huge power draw for the FM systems. In the classroom, the children use the FM systems so that they can hear the teacher directly to their aid, whether it's a hearing aid or a cochlear implant. Right now, that's a huge power draw. So using rechargeable batteries is not enough. So hopefully we'll be able to get some good technology in the future that will help with that.
So I want to wanted to make a comment about Diane's job. So I think being the teacher, I mean, you're getting the kids down the road a bit from us. And the teachers really have, I think, and it took me a while to figure this out. I mean, because when I started doing this kind of work, I didn't have children of my own, which is very helpful. But teachers have a much broader job. They have, in many ways, a much harder job. So, we can have children who implant you to come in, and the audiologist is all excited about how well they do on their tests, and the children are talking, and everything seems fabulous. And that's great. But the fact that we're telling the parent that their child's doing well on the types of evaluations we do is not a guarantee for academic success. And so you have a much broader charge, and I think in many ways a more challenging job. And I don't think that that's something I can remember years ago sort of talking to the team about and saying, just remember the fact that they're doing well with us doesn't mean that they can't be having challenges, and that the teachers have a lot of other responsibilities as well.
Yes, well, I mean, I also, and back to that idea of distractions are big. And when you're in a one-on-one situation, it's very different. And I mean, distractions are big for any kid, right? But like in a class, when you have hearing loss and there's a lot of visual stimulation around, and a kid might need to rely on their visual, they might need to be able to have to watch the teacher to get as much as they can, and yet there's too much else that's interesting to look at, can really affect their progress in school.
That's very interesting, and so very true. It's hard to get kids to focus when they need to. So at this point, is there anything else you wanted to add before we go into? I have some questions that the audience had sent in already that I'd like to address. Okay, we'll head right into questions and answers. So this one is I think a school-related one. So Diane, I'll hand this to you. How can I best support a class of deaf, hard of hearing children? Do they tend to get mentally, physically exhausted?
I think that exhaustion is very real, and you definitely, I see it. So yes, the kids can get exhausted from listening. They can have listening fatigue, but they can also they can be tired of watching too. If they're getting a lot of visual information, it can be exhausting that way. So I think as teachers, we can be empathetic, and also to build our routines around these anticipated times. So if we know they're much more alert in the morning, we got to do our language stuff in the morning, like all that important stuff in the morning, and then in the afternoon, not that the play-based stuff isn't hugely important, because it is, but you'll tend to get kids much more actively staying with you if it's child-focused, right? If they're doing what they want to do and you can just insert yourself into their play, it's a great way to sort of deal with that fatigue. Also, as teachers, I think to support deaf and hard of hearing children, we can provide a language-rich environment. And I've sort of been thinking, I wonder if I need to explain that. The way I think about that is just have things that the kids want to talk about. So if that means switching stuff up, my kids are so aware of any change that I make in the classroom that they, if I put anything, any different thing, they want to talk about it. They want to know what is going on. So, just have different stuff around, change stuff up. Put stuff on walls, not too much stuff. Put stuff on walls, not too much. And provide opportunities for children to interact with each other. I think we are so worried about using every minute of our day to provide instruction, and we forget that it's so important to pull back and let them interact with each other. Because especially when the 3 and 4-year-olds, they come and they may not have a lot of language at first, so I feel like I'm doing all the talking, and then it gets to a point where they start to interact, but mostly with me. And then but about this time of the year, it's so exciting because then I can kind of step back and watch, there's conversations happening just, between them, and that's super exciting, but you have to let that happen. You have to find time for that, right? So allowing that, and also fostering independence, let these kids do what they are capable of doing. I think it's common for us to baby them when they're little. And shape behavior by modeling good behavior and modeling happiness and excitement.
Well, no, that's a really good way to look at it. Okay, next question. All right, Dr. Young, I'm going to let you take this one. What does the research now show about the effectiveness of cochlear implants and age of recipient? I think you've kind of covered this.
I'm sorry, I didn't hear the end of the question.
The effectiveness of cochlear implants and age of the recipient.
Well, I mean, I think we kind of covered this. So
covered it, yeah.
minimizing the period of time that the brain is deprived of auditory input, the ear and the brain is deprived of good auditory input, is of benefit. And there's that. So here's the thing. So there's a tremendous amount of research on that, but that's when they analyze group data. So the fact that that's true when you compare this group to that group doesn't mean that we can take a child implanted at 7 months and say you're going to do better than the one implanted at 12 months. It doesn't. That doesn't work on an individual level. That's why we're interested in using other individual markers so that we can actually predict on an individual level. I mean, I will never forget, brains are amazing. I'll never forget, I implanted many years ago the child of a woman who was the head of a communication and science department in Illinois. And this child went to, do you know what IMSA is? The Illinois Math and Science. This child had never heard. This child was one of those amazing people that was always an implant candidate and had intelligible deaf speech. So it didn't sound like a hearing person, but you could understand. And she was doing very well in this Illinois Math and Science Academy. And I really thought that at age 18, which is, she was in her last year and she was 18, I really thought that her progress would be slow at that age, right? Not at all. Not at all. I mean, she was amazing, and there have been people. There are just people like that, but we don't know if we're dealing with that person. So I would never say to someone, well, "Wait till you're 18." That's the exception that proves the rule. Okay.
Okay. All right. So this one, Dr. Michelle, maybe I'll give this one to you. So, why do my Baja students leave off their hearing aid more than any of the other students? Hearing aid and cochlear, and is there research showing that this happens, or is it my imagination?
I don't know if there's actual research, but clinically, we see it all the time. It's kind of just thinking about it, especially for kiddos that are using the Baja on a soft band. I think it has something to do with the soft band. Wearing that headband or the sound arc behind the head can get uncomfortable. I also think for children that have unilateral hearing loss, almost if the Baja becomes a distraction, especially a noise. So if the classroom gets noisy, the first thing they want to do is take that off so they just have one ear working to kind of quiet things down. The other thing, too, is Bajas are tricky with making sure that the placement's correct so that the child's actually getting the true benefit of how it's programmed. So, if a kiddo's been at school all day, they're wearing their soft band, they've been moving it around, maybe it's not in the exact position that it should be, and then maybe it actually isn't providing them with the benefit that it should be, and so it's just easier for them to take it off. Feedback is another thing. So if anything is touching the Baja, we get some feedback a lot of times, and especially for our older kiddos, that's embarrassing for your processor to be squealing, your Baja to be squealing while you're at school. Like I said, I don't know if there's proven research, but I know that we see it in the clinic all the time. That is our biggest struggle. Teachers are like, I don't know what to do with this thing. Why do they keep taking it off? And I have no good answer.
One thing that could be contributing for some of these kids, and I'm thinking more for your school-age kids that have the implant, but it certainly would apply to the soft band too, probably more so. And that is that and this is about to, I think the field is really about to really flip. So the traditional, the bone conduction systems traditionally there's been vibration, and then that's transmitted to the internal magnet. and that vibration vibrates the skull, and that stimulates the inner ear. So these are not patients in general with sensory neural hearing loss. These are kids with just a big conductive loss. The sound needs to get in there, right? So there are newer, the problem is that vibration is irritating to the skin. And so I was surprised to learn that many of these patients don't wear them for more than 5 or 6 hours a day. I mean, that's actually, I think, pretty good, right?
Yeah.
So there's these new active bone conduction systems. The first one that was FDA approved was about a year ago. And a second one was just approved by another manufacturer recently. And so it doesn't, there's no vibration of the skin. Somehow the signal is sent in, and then there's like an actuator in it. So I think that we're going to see kids being able to tolerate longer use. So I hope that helps in the future. But it's all fairly new in terms of the U.S. experience.
Okay, this is another school one. So Diane, what advice or resources would you suggest for school mental health professionals working with children who may be deaf, hard of hearing? So that's like a different component.
Yeah. So I think we've also, I've heard some others say too, that it's important for kids to know other people who are in similar, who also have hearing loss. I mean, that's pretty powerful, right? You don't want to be the only one. So I think one thing I would suggest is to seek out that. So whether through deaf events, there's deaf events that happen. There's an organization called Deaf Illinois. I think they have a Facebook page. They post all kinds of events on it. Somebody mentioned Chicago Hearing Society, I think you did earlier. They have a deaf mentorship program, which is amazing, and they will have a deaf mentor who can come to your home and work with your family and just hang around your family, and it's empowering for a kid to know somebody else. The Illinois Service Resource Center is one last organization that I love. They specifically offer behavior support for children with hearing loss. But that can really be, for parents who may be struggling with their child, and it might have something to do with mental health. But they're just great. They'll come to the house. They'll come to the school. They're very helpful. So.
Okay. And I'll also add to that on our website, FHSR.org, we do have a lot of resources, and we continually work on adding those. So that might be a good resource as well as what Diane mentioned. I think we have time for one more question. And since we love music, Brandy, I'm going to give this one to you because I know Brandy's worked down the hall for music therapists. What techniques could I implement in my music classes in order to maximize learning?
That's a great question. I think anything in a class form can be difficult because you have diverse learners within a group. So I would suggest doing a lot of our different listening and spoken language strategies within your music class. So for instance, I might start singing a song and then stop and pause and give an expectant look and some wait time to see if they can fill in the next part of the song. I'd also probably do a combination of songs with instruments as well as songs without instruments, so that potentially some of our newer listeners could hear the actual words of the song that you're singing. First, if there's a lot of noise with the musical instruments, it might be kind of tricky to hear what is actually being said. I would also try what we call an auditory sandwich. So I would say the verse or say part of the song and then show them some sort of visual, whether it's a sign, if they're signing, a picture, a gesture, a hand motion of that song. I'm thinking Wheels on the Bus in my head, so that's kind of where I'm going. And then say it again. So they hear it, then they can see it, and then they hear it again. Because that works on them listening first, then seeing, and then listening again.
Okay, thank you. Okay, so I'd first like to thank my panelists. Thank you so much. You've given us so much to talk about, and I realize they could all share probably days worth of information. So reach out if you have questions. And I'd like to thank the Columbia College students and staff because you've made this really wonderful space to be in and given us a wonderful opportunity to meet. I'd also like to thank the board of FHSR and the associate board, and of course Kristen and Jean and Benj for all of the things that have to happen to make this look effortless. So thank you. And it's important, again, for everyone to remember this is just the beginning of the conversation. We're just starting to figure out how all of this fits together. So the video from this will be posted at some point on FHSR.org, so please make sure we have your contact information. Reach out to us on social media, Twitter, Instagram, Facebook. Another reminder that the reception afterward will continue for a few minutes. So if there's someone you do want to talk to or you saw across the hall and was like, oh, I meant to go talk to them, that will give you a really nice opportunity to do that. And then at this point, I'd like to introduce, again, our executive director, who has a few final words and an exciting announcement about stuff coming up. So all yours.
First of all, can we get a round of applause for Heather and all of our speakers? Thank you. As both a professional and a parent, I can't thank you enough for all of this information. It's amazing. And truly, what Dr. Young speaks of with it being a community and she is simply the surgeon is really what she's been saying for years. When she implanted my son, which I just figured out literally was 12 and a half months ago, or 12 and a half years ago, to almost to the date. She looked at my husband and I and she said, listen, I can do this surgery, but what the outcome is what you guys make of it. And it's the work that you put into it. And it was the work of the speech language pathologist, the oral HAB, it was the teachers, it was the specialists who were with us, the audiologists who did the programming. It is truly a team effort. It's the parents, it's the community, it's everybody sitting here. This is really your group. And the parents who figure that out are really the ones that are able to leverage that and help their child to be that much more successful. So thank you, ladies, for all of you giving your time tonight and helping teach us really what we need to know about how to be more successful and help our kids have more successful outcomes. I greatly appreciate your time. A couple of housekeeping things with FHSR. We are so excited to be launching in the spring an education toolkit. So the goal of this toolkit is to be online through our foundation website, and it will be a support system for both educators, for parents, and for children who have hearing loss, and how they go through and navigate early detection, early intervention, and then that transition into school. We really feel like we want to step into this and help support those families and the educators and the children directly. So that will be something that's coming hopefully in the spring of 2020. And then I'm also excited to announce that we are going to be launching an advisory board coming in 2021. So all of the professionals who are sitting in this room, we would love to have your input and your insight. It is something that we've wanted to do for a long time. So we are excited to continue that partnership and get a little bit closer to those of you who are doing the direct service, who are knowledgeable both in the hearing loss world and also education and music. It's important to us as a foundation that we remain informed so that we can make the right choices moving forward for programming so that our programming actually works to support the kids and we're putting our dollars in areas that are important that will help get them on the path to success. So those are two exciting things going on. We have a couple of great events. We are committed to community. We have a wonderful associate board who works very, very hard to put on some great events. We have an event coming up this Sunday, Bowling with Friends. We know how important it is. Diane mentioned that kids with hearing loss see other kids with hearing loss. It is low incidence, so our kiddos get turned out into the world and they can go all day, all year without seeing another kid with hearing loss. So we try and bring that community together through our free family events. We have Bowling with Friends on actually this coming Sunday. And then in April, we'll have our 9th annual Cheers for Ears, which celebrates the power of hearing and music in our children's lives. And we are so excited to continue to bring that to you. When you really come and see that, the families who attend are so excited to talk to other parents who are in the same position that they're in and to have their kiddos see other kids who have hearing aids and Bahas and implants and everything's beeping and lighting up and they're so happy to see other kids who look just like them. So that's a wonderful event. We do have our fall fundraiser coming up in November of 2020, and that is going to be an event that features Third Coast Percussion, which is a Grammy Award-winning percussive group that's actually based here in Chicago, and that's going to be at DePaul. So be on the lookout for that information. But once again, Heather did a great job thanking everybody. I'd like to extend my thanks to Columbia College. They have really stepped forward strongly to partner with us and open up this facility. The students are all fantastic. All of the educators and advisors and support staff are amazing. Thank you to our esteemed panel. Thank you to Heather and to Dan for being such a great committee to putting on this wonderful event, and to Jean Kaiser, who is our manager, who none of this would happen without her. She is definitely the magician behind the curtain. So thank you to all of you for attending. I hope you enjoyed this. Have a wonderful night. Please do join us for a glass of wine and hopefully a couple of questions and to continue the conversation.